All right, I think I will get into our intro so we can get into the content today. So, hello everyone, and welcome to today's presentation. I'm Erin. I use she, her pronouns, and I am the moderator for today. You won't be hearing too much from me. I'll mostly be in the background, but I want to get us situated in this space so we can all be comfortable and get the most out of it. So the first thing you will have noticed when you arrived is that we are recording today's session. This is just for internal quality assurance purposes. We like to let folks know so they can feel comfortable in the space. Next, there will be a few features to pay attention to on your screen. There should be a ribbon at the top or bottom of your screen. If you can't see it, it might be minimized, so you might just need to swipe your finger or your mouse across and it should pop up. There are going to be three main buttons to pay attention to. The first is the chat pod. This is the place where you can ask your questions, make comments throughout the presentation. You have the ability there to choose who you're asking your question to or to show it to anyone. That is a good place if there does end up being any sort of technical difficulty to let me know. Again, Erin, feel free to find me and send it directly to me. Next to that, there is our Q&A pod. This is another place where you can ask questions, and it has the added feature of letting you be anonymous if that makes you more comfortable. We have no preference. We want to be able to answer all the questions you have, so please feel free to send those there. And the last button along there will be a button that either says CC or captions that is available to you. It only affects your screen, so feel free to turn them on or turn them off at your own discretion. This session benefits a lot from your participation and using these features, so we encourage you to. It's what we're here for. We love engagement. And before I pass it off, I will just be doing two more things. So first, I will explain who egale is in case you're unfamiliar with us. So for those of you who don't know us, egale is Canada's leading organization for 2SLGBTQI people and issues. We improve and save lives through research, education, awareness, and by advocating for human rights and equality in Canada and around the world. Our work helps create societies and systems that reflect the universal truth that all persons are equal and none is other. And the final thing I'll do before I pass it off is share egale's land acknowledgement. So although we have participants joining us from various locations, we at egale are located in downtown Toronto. And as such, I would like to take a moment to acknowledge that we are hosting this webinar on the traditional land of the Huron-Wendat, Seneca, Mississaugas of the Credit, and Haudenosaunee people. It is also important to acknowledge that I myself am a settler on these lands that Indigenous peoples have been living and working on since time immemorial and continue to have community on today. The social and economic powers afforded to settlers today is deeply tied to its history. It is important that all settlers today recognize the contributions and historic importance of Indigenous peoples and to commit to making the promise and the challenge of truth and reconciliation real in our communities. I ask that we all remain cognizant of the colonial context in which we are embedded as we reflect and discuss the topics of this session. And with that being said, I will pass it over to our presenters today. Thank you.
Thanks so much, Erin. And thanks everyone for attending today's webinar. Felix and I are really excited to share with you some highlights from our Queering Mental Health Supports in Canada project. So a little bit about us, the QMH research team. I'll start us off with Felix introducing himself.
Hi, everyone. Thank you so much for joining us. My name is Felix Demel-Fidel. I'm a senior research officer at egale. I'm joining you from Tiohtià:ke, Montreal, traditional land that is taken care of by the Kenyan Kahaga Nation. And happy to be here and talk to you about QMH.
Thanks so much, Felix. My name is Kinzaida. I use she, her pronouns, and I'm joining you from what is colloquially known as Gatineau, the land of the Algonquin peoples. I'm also a senior research officer here at egale Canada, and I was the project lead for the QMH, or Queering Mental Health Supports in Canada research project. And I'd also like to send a shout out to our director, Dr. Brittany Jakubiak, who directed and oversaw this whole research project. Also a note that the project was funded by the Slate Family Foundation. So before we go into the research findings, I'd like to provide a brief project background along with the methodology and some of the methods that we use throughout the course of our research. So firstly, what is this project and why did we do it? So The QMH project is a multi-year, multi-method project focused on better understanding the COVID-19 pandemic's impacts on 2SLGBTQI mental health in Canada, as well as emerging challenges in addressing 2SLGBTQI people's mental health care needs. The project involves training, research, and knowledge mobilization, and is focused on both identifying and addressing critical gaps in 2SLGBTQI mental health care in Canada. So why now, and why are we doing this project? 2SLGBTQI people are falling through ever-widening gaps in the Canadian mental health system, including related social services that focus on things like housing or employment or food security. The pandemic has heightened rates of mental health disorders like anxiety and depression and substance use, and compounding this problem, exclusion and discrimination in healthcare systems prevent 2SLGBTQI people from accessing the inclusive services and care they need to manage their mental health. The impetus behind this project is the rise in mental health care needs among 2SLGBTQI people since the beginning of the pandemic, as well as the troubling lack of affirming and culturally responsive mental health care. By identifying and addressing these critical gaps, it is our hope that the QMH project will ensure that the unique experiences, needs, and care requirements for the mental health and well-being of 2SLGBTQI people are being addressed amid COVID and beyond. So the project had a few goals and objectives. The first objective of our project was to understand the impacts of COVID-19 on various social determinants of mental health among 2SLGBTQI people in Canada. So what do I mean when I say social determinants of mental health? The World Health Organization defines these as the conditions in which people are born, grow, live, work, and age. And these include a lot of factors, but the ones that we'll focus on mostly today are things like access to medical care, access to mental health care, housing, and employment. So for example, research has shown that having stable and appropriate housing is a key facilitator of good mental health. The second objective of this project is to improve the cultural responsiveness of mental health and social service providers by creating a custom evidence-based virtual training program. And we can expand a little bit more on what the training program entails in the Q&A. The ultimate goal of the project is to increase the number of safe, inclusive, and identity-affirming mental health services in Canada so that the mental health care needs of 2SLGBTQI people are better addressed, ultimately leading to a decrease in mental health inequities. A little bit more on the phases, since I noted earlier that this was a multi-year project. So phase one of the research project took place between August 2021 and August 2022. And in this phase, we really focused on addressing immediate pressing needs by delivering basic cultural responsiveness training to over 1,200 service providers. All trainees completed pre-webinar surveys, which asked folks, what is being done well with respect to 2SLGBTQI inclusion in your field, and what is being done well on that front in your personal practice? We also asked people, what concerns do you have about 2SLGBTQI inclusion? And we asked them that question both in relation to their field in general and in their practice specifically. The main findings of these surveys after we analyzed them were that there's a lot of room for improvement, especially when it comes to training and educational opportunities, and there are widespread knowledge gaps. For example, a lot of respondents and people who took those surveys told us, I don't know what I don't know. In phase two, we began the research. So the research phase took place between May 2022 and January 2023. And in this phase, we really sought to better understand the impact of the pandemic on 2SLGBTQI people's mental health care needs, as well as the needs of mental health care providers who work with 2SLGBTQI people. Our research was guided by 4 frameworks, namely social determinants of health, minority stress theory, intersectionality, and trauma-informed approaches. Phase 3 is the phase that we're currently in. So phase 3 has been focused on developing a training program that's based on our research findings. Our learning team is currently finalizing the service provider training, which is a 4-part online, self-led, and cost-free training program, and it's going to be launched in the coming months. Phase 4 will be the actual launch and distribution of the virtual training program nationally later this spring. And then the final phase of the project will begin approximately in the fall of this year, going into the spring of next year, during which we'll evaluate the training comprehensively using multiple techniques like semi-structured interviews, as well as widespread surveying. The 2 main research questions that guided the QMH project were, firstly, how has the pandemic impacted the social determinants of mental health among 2SLGBTQI communities in Canada? And secondly, what gaps and challenges do both 2SLGBTQI and allied mental health and social service providers identify and face themselves in delivering inclusive care for 2SLGBTQI people in Canada? So I'll pass it off to Felix to continue on providing more details about our research activities.
Great, thank you, Kim. So as Kim just said, I will tell you a bit more about the research activities for the project. So to answer the research questions that we detailed in the previous slide, we conducted a number of research activities, including a national survey in which 214 of the 304 respondents were 2SLGBTQI service seekers, while 90 of them, the respondents, were service providers. We also conducted 8 focus groups and 5 individual interviews, in which 42 of 61 participants were 2SLGBTQI service seekers, and 19 were 2SLGBTQI or allied service providers. In January of 2023, we also hosted a virtual community consultation event to provide an overview of our findings and to give community members an additional opportunity to provide input into the proposed training. Throughout these research activities, we continually collaborated with the Community Advisory Committee of 6 people to get their input on survey scope and content, recruitment, and also how we were collecting and interpreting our findings, as well as mapping out our training program plans. We then wrote the final research report, which was recently launched on the project landing page, which is hyperlinked here at egale.ca/QMH. For the next little bit, I will be talking about some of the research findings from the project. And the first social determinant of mental health that I'm going to highlight is that of access to mental health care. So by far, the social determinant of mental health that was most widely impacted by the pandemic was access to mental health care. Many study participants expressed the need for more affordable and accessible mental health care, for example, more comprehensive insurance coverage and more providers offering free or sliding scale services. Further, 61.5% of survey respondents noted an inability to afford care was a reason for delaying their mental health care. Focus group participants also cited various reasons for delaying mental health care, including cost, a shortage of competent providers, and concerns about burdening providers operating within a strained mental health care system. As Heather noted, if it's not an emergency, don't burden the system. Access issues were particularly pronounced for individuals experiencing intersectional marginalization, for example, identifying as a person living with a disability or as racialized. As Mandy explained, for me, personally, accessing supports that I need, especially the more identities that you hold, the harder it gets to find services that are going to be appropriate for all of you. Another social determinant of health was access to medical care. So our findings showed the extent to which the pandemic has created barriers to accessing medical care. 76%, or 231 of survey respondents, indicated that the pandemic had negatively impacted their access to medical care. These access barriers are particularly pronounced for those seeking gender-affirming care, as Sam explained. I can't get a family doctor, and to be even pickier and say now I want a gender-affirming doctor, it's like virtually unheard of that there'd be availability for that. Unless I'm looking for specific transition services, which I'm not, I just need a doctor who understands. Given doctor shortages across the country, some participants talked about feeling trapped or making do with a provider who can provide them with the bare minimum, such as filling prescriptions, but not necessarily 2SLGBTQI affirming. Another SDH was social support. So negative changes in social support were mentioned by most survey and focus group participants. Some participants noted that the widespread lack of social support has created twin pandemics of COVID-19 and overdose deaths. Negative changes to income and other resources left less energy to mutually support fellow community members, but even so, formal and informal peer support were key to addressing pandemic-related stressors. 65% of survey respondents had someone to whom they could turn for suggestions on how to deal with a personal problem, while 61% indicated that they had someone to love them and make them feel wanted. Another one was peer support, and I will not provide a thorough explanation here because Kim wrote a wonderful research brief. So if you want to read more about peer supports as a way that participants dealt with pandemic-related stressors, use the QR code to check out our brief, and I will give you a couple of seconds to capture the QR code. Another way to access it is via the landing page, so egale.ca/QMH. Just give you a couple of seconds. All right, so I think we can move on to employment. So steady employment is one of the determinants of mental health most directly impacted by the pandemic. Although employment-related problems were not widely discussed in the focus groups, nearly 35% or 106 survey participants indicated that they'd experienced negative changes in their employment as a result of COVID-19. These negative changes had correspondingly negative impacts on mental health. One survey respondent living in a small city in New Brunswick shared the despair accompanying the inability to find employment. I've been unable to find work since the pandemic started, and I'm unable to find any motivation or desire to run a business like I had planned pre-COVID. It feels hopeless to not hear back from any of these jobs. It just feels like all I can do is sit and wait until I run. However, 26% of survey respondents experienced positive changes to their employment, leading to better mental health. For example, a survey respondent living in rural Saskatchewan connected employment, social support, and better mental health. I'm working in a much more supportive atmosphere now than prior to the pandemic. My mental health has greatly improved because I feel more valued and that my voice matters. It is not easy being different in some working environments. Another determinant was that of food security. So the results, in our results, 32% or 97 survey respondents experienced negative changes to their food security during COVID. A higher proportion, it's worth noting that a higher proportion of people living with a disability had experienced negative changes to their food security, 45%, than people living without a disability who noted they had experienced negative changes to their food security. So we have 21% versus 45% of disability. Food insecurity causes anxiety and stress and is interrelated with other social determinants of mental health like income and housing. Notably, 44% of our survey sample identified as someone living with a disability, so we wanted to explore this connection between living with a disability and food insecurity, given the literature on economic precarity more generally among people living with a disability. The next social determinant of mental health is housing. So 35% of survey participants had not experienced any housing challenges since the start of the pandemic. That means that 65% had experienced some housing challenges since the start of the COVID-19 pandemic. Of those, 23% of survey respondents noted they had difficulty finding a new place to live, 14% borrowed money to pay rent or their mortgage, 14% needed to move in with family and friends because housing was not affordable, and 11% of participants also highlighted other housing challenges, including domestic violence, maltreatment, or harassment. Housing instability had negative mental health impacts, as this quote from a bisexual queer woman living in a small Ontario city showed. It's been very, very difficult. Both my income and my partner's have been reduced. We recently got a rent increase, and we can't afford it without giving up money for food or to feed our cat or for medications. But we can't move anywhere else because everywhere else is already more than what we are currently paying. It's a lose-lose situation with housing that makes me depressed and constantly anxious. In addition to asking people about the pandemic's impacts on social determinants of mental health, we also wanted to get a sense of adaptive responses to these impacts. We used many metrics to measure hope and optimism, as you can see on the graph right here. And we found, for example, that 52% of survey respondents felt optimistic about their future, 47% felt a sense of belonging to their community, and 39% felt good most of the time. While these numbers should be higher, and we hope that they will get higher in the future, it is a silver lining given the severe impacts of the pandemic. In addition to the numbers that we talked about in the previous slide, it has been shown that 2SLGBTQI people are particularly resilient, being able to cope with minority stress and discrimination. In our survey, 55% of respondents, including both service providers and service seekers, felt that they could achieve their goals despite obstacles, including the COVID-19 pandemic. Half of the survey respondents also felt like they were able to adapt to change, a skill that was necessary to power through the challenges that the pandemic imposed on 2SLGBTQI people, and 46% felt that they could bounce back after difficult times. Again, our interpretation of these fairly high numbers is that 2SLGBTQI people are resilient, and that this resilience contributed to helping people go through the pandemic. So although a lot of our research findings highlighted some dire needs, they also illustrated the coping strategies and resilience 2SLGBTQI people demonstrated as they navigated difficulties created or exacerbated by the pandemic. In addition to participants' engagement in a wide range of health protective strategies, participants displayed optimism, talking about the silver linings of the pandemic, as Samara's quote illustrates. I found the pandemic, as horrible as it's been, to be this beautiful catalyst for gender exploration without anyone else around to judge or see who I was in a way that I didn't want to be. And so someone who's more masc-centered but was born into a female body, it was great for me to see how do I feel wearing the clothes that feel good on me without that fear of judgment or anxiety that comes with other people seeing it. I think that was an important shift to understand my discomfort wasn't about being trans, gender, non-conforming, or masc. It was with society's judgment of those identity facets. So that concludes the first part of the research findings. I'll pass it on to Kim to talk about further research findings here.
Awesome. Thanks so much, Felix. So as Felix just noted, this part of our presentation pertains to our second research question, which asked, what gaps and challenges do 2SLGBTQI and allied mental health professionals and social service providers identify and face in delivering inclusive care for 2SLGBTQI people in Canada? So in the coming slides, I'll highlight some of the main themes that emerged when analyzing for this second research question. The first theme pertains to training gaps. So a key training gap noted by many participants was that of a lack of nuanced training that goes beyond the basics. So several service providers talked about how broad and vague the 2SLGBTQI training that they had received to date was, and this was often coupled with recommendations to dig deeper. An addictions counselor working in a nonprofit stated, I think the training we do receive in this area is extremely surface level and repetitive. I don't think there's a lot of work on challenging ourselves further than simply listening to someone share basic information. Another provider noted, the thing that really grinds my gears is that they try to do this one size fits all. So making the training relevant to your sector is super important. A lack of ongoing training was another related training gap. So multiple service providers talked about the need for ongoing training and how cultural responsiveness should be evaluated continuously because terms and promising practices evolve over time. And so as a result, providers who have been in the field for many years, for example, are often the most in need of receiving updated trainings. A third training gap that people noted was that of specific training on intersectionality and trauma. One LPN working in PEI, for example, told us that trauma-informed approaches was not included in any of her education, and that there was only one mandatory gender and sexuality introductory seminar. She linked this gap to the overt transphobia she witnessed amongst her coworkers, which only caused overt harm and further trauma. A therapist working in public school spoke about the need for training specifically on intersectionality, telling us, I work with many BIPOC youth who are also part of the queer community, and I could use more specific training or research and resources that would be relevant to this intersection, especially trans, Mask, Black, and Indigenous youth. So another key theme was closely related to training gaps, but it's that of knowledge gaps. So this was one of the most prominent concerns indicated by service providers. And for some, this was a general knowledge gap, like I had noted earlier, kind of indicated by the refrain, I don't know what I don't know, as well as just a general lack of awareness of 2SLGBTQI clients' needs in specific circumstances. There are also more specific knowledge gaps. So again, respondents cited knowledge gaps regarding intersectionality. So for example, how to navigate cultural differences, as well as the needs of intersectionally marginalized clients. And a queer service provider, for example, working in Northern Canada, asked, how does being queer and racialized impact somebody? How does being queer and disabled impact someone? Intersectionality is so important, and most of the people seeking services will be living with some type of intersectionality. So that concept is one that not even a lot of service providers know or take the time to understand why it's important. Similarly, respondents highlighted knowledge gaps regarding how minority stress and trauma impact their clients' presenting needs. And this is particularly true for trans and gender diverse clients. So without knowledge of the sociopolitical or economic and cultural factors that influence 2SLGBTQI people's mental health, it's impossible to have the knowledge of what is required to be a quote unquote safe practitioner, nor to be able to start to dismantle oppressive systems that lead to health disparities in the first place. Even providers who are well-intentioned risk causing serious harm if they don't recognize the gaps in their own knowledge and skill set. Our participants recognize this risk of harm and stress the importance of filling knowledge gaps in order to better support people and or direct clients to appropriate resources. Another common theme focused on referral and systems navigation challenges. So one of the first sub-themes within this broader navigation challenges theme was that of the inability to refer due to structural issues. For example, pandemic-related burnout among peers or fellow service providers. So several service providers whom we talked to discussed the compounding issue of increased mental health care needs and decreased resources among service providers, in part driven by burnout. One participant noted, we will likely never see the amount of well-trained people that we had previously. They left because they were too burnt out and nobody replaced them. There were other providers for sure, but they were just not in any way, shape, or form qualified to help the people who were seeking them out. In some cases, this combination of increased need and decreased availability of suitable providers led to tragedies such as suicides and overdoses. A second referral challenge was rooted in a lack of trans-affirming providers. So several of our service providers noted that they and or their peers were comfortable or familiar working with sexual but not gender minorities, creating a systemic lack of truly trans and gender affirming providers with expertise in gender affirming care. One trans provider noted that they had to take down their personal advertising from everywhere, online, on like hard copies in libraries, that sort of thing, because they didn't want to spend their time sending emails saying, sorry, I have a wait list, I can't take you on. And they told us about the waves of people that would reach out to them out of sheer desperation and feeling the pressure to not being able to meet that need. So this pressure, this type of pressure caused by high demand and low resources led to a secondary challenge was that service providers, especially service providers who themselves identified as 2SLGBTQI, felt immense pressure and ethical obligations to operate beyond their scope of practice and area of expertise. So as one queer service provider shared, I feel like I'm on a little island where I'm a support and my client is there with me. But then when we're outside of that, there's so few resources, especially affirming ones for folks facing multiple experiences of marginalization. So many clients on my caseload have experienced trauma from cis therapists in the past, and working with that makes me feel really helpless about the system because there aren't services to refer folks to. And then they'll come to me presenting concerns that are way outside of my scope of what I feel comfortable in. And then how much do I respect a client saying, I see myself represented in you and that's all I need, versus me saying, I don't have skills or I don't have the skills to support this specific concern, but there's nowhere to refer you where you see yourself represented and get that support. So I really feel stuck, and I'm either saying, sorry, I can't, with no referrals, or I'm treating someone outside of my scope because what other options are there? So I found that quote really encapsulates this catch-22, or this difficulty that a lot of 2SLGBTQI service providers found themselves in, of feeling this pressure to operate beyond their scope of practice, knowing what the harms could be if they sent someone out with no referrals. A final theme that was related to our second research question was the specific challenges of 2SLGBTQI service providers. So the previous theme touched on this a little bit, but now I'll get into it in a little bit more detail. So the first challenge that was quite unique to 2SLGBTQI service providers was that of maintaining financial stability while also trying to address growing and rising community needs. Multiple 2SLGBTQI service providers talked about how they felt that there was an onus on them to shift their fee structure or provide pro bono work, because they felt that the purpose of their work wasn't to make money, but to help, and I quote here, but to help support folks so that they don't die, unquote. Because of their own lived experience, they know the disproportionate rates of poverty in the 2SLGBTQI community, but highlighted how charging less or nothing caused them to, quote, remain oppressed within the system, unquote, relative to their cishet peers. Another provider talked about how many of their peers, especially racialized queer and trans providers, were going into private practice in efforts to try to be better able to take care of themselves and meet their own financial needs in the context of rising living costs, as well as to avoid the burnout that often accompanies working in the public sector. This in turn exacerbates a lack of affordable mental health care options, as well as providers who are themselves members of the communities they are serving. A second challenge specific to 2SLGBTQI providers was having their own needs met, especially given a lack of services for service providers. As a gay service provider in Atlantic, Canada shared, it's feeling alone and also pressure to volunteer time, to reduce rates, to find space, when I also have to take care of myself. So I think that's a difficult part about being a member of the same community I'm trying to help. I see myself reflected in the struggle, but then I also have to take care of my own family and my own mental health and have boundaries. Finally, a third challenge was that of keeping professional and personal identities siloed. And this was especially challenging in non-urban contexts or rural and remote communities where the populations are quite sparse. So as a queer service provider working in Northern Canada mentioned, if I refer clients to services, then I can never access them myself. Everyone's my friend or my colleague or referral, so it's impossible. Additionally, service providers who are 2SLGBTQI describe their own experiences of inaccessible or harmful mental health care, feeling isolated and needing connection to other 2SLGBTQI providers. Because they'd experienced it themselves, they often overextended themselves in efforts to help 2SLGBTQI clients in their own struggles. But unfortunately, this overextension often resulted in burnout. So as we've seen in today's webinar, both Felix and my discussions of the two different research questions, egale's Queering Mental Health Supports in Canada project provides several key insights into the pandemic's wide-ranging impacts on 2SLGBTQI people in Canada, as well as their emergent needs. So to kind of summarize it all, what are these emergent needs? Firstly, we need more accessible mental health care. Secondly, we need more 2SLGBTQI service providers and queer-specific services. Third, and again, please feel free to read the data brief that the QR code had directed you to earlier to read a little bit more about this. But another emergent need is a need for more robust peer-based supports. And finally, we need more integrated services that mirror the interdependence of social determinants of mental health. So as you've likely seen today, all of the factors that influence mental health, whether that be housing or employment or food security, they're all interrelated. And we need mental health and social services that recognize and respond to these relationships. As stated at the outset of this webinar, the ultimate goal of both the research and the training that we'll be launching in a few months is to ensure accessible mental health care despite the severe consequences of the pandemic, and to increase the number of safe, inclusive, and affirming mental health services in Canada through community-rooted service provider training. The goal of the training we've developed is to have healthcare providers and sector leaders bring back learnings to their workplaces and practices, influencing their organizational cultures and policies regarding 2SLGBTQI inclusions. These structural shifts will ultimately create services that are better equipped to support the mental health care needs of 2SLGBTQI people, and will lead to a decrease in mental health inequities facing our communities, particularly in the wake of the crisis, the COVID-19 crisis. So here is a screenshot of our developing online training. It is a 4-module interactive program, as I noted earlier, incorporating both service recipients or service seekers and service providers' experiences. Specifically, it builds on the needs identified by participants in earlier phases of the research, including strategies on how to provide safer and more affirming care, incorporating intersectionality to address the needs of, for example, racialized 2SLGBTQI clients or those living in rural, remote, or northern areas. And the training also includes strategies on how to adapt to more virtual care provision. So a lot of services moved online in the last 3.5, 4 years. So how can service providers adapt to those technological and socio-political shifts that have been happening in the last 3 or 4 years, as well as how to respond to the needs of 2SLGBTQI service providers themselves. So for folks who are part of the communities that they serve, as we discussed previously, how do we best respond to those folks' needs and address things like burnout and vicarious trauma? So the first module that you see here features some lovely artwork from a social artist, Melanie Schambach, and reviews content from the Inclusion 101 trainings that egale's learning team already provides. And the second module puts forward some of the theoretical foundations of the training program that I'd listed quickly earlier. And those are the social determinants of mental health, intersectionality, minority stress, and trauma-informed care. And we're doing this, we're providing these theoretical frameworks in order to move beyond biomedical and individualistic understandings of mental health to more holistically address 2SLGBTQI mental health disparities. The third module aims to create safer mental health care with a focus on cultural safety, anti-oppression, and neurodiversity affirming care. And the fourth and final module explores how the field of mental health care responded to pandemic-related challenges by adopting alternate strategies and modes of delivery. And it also provides learners with specific strategies on how they can dismantle financial, geographical, and physical barriers to care. So this is really focused on addressing that emergent need that I'd noted earlier, which is to make mental health care services not only more accessible, but also safer. And I'd also like to note that throughout all of the modules, there's lots of videos, lots of little vignettes of actual service providers, of actual service seekers, telling learners what they think, for example, providing or receiving trauma-informed care looks like, providing and receiving culturally responsive care. So it's not a big bunch of text and big blocks of text. It also involves a lot of audiovisual components. So we're really excited to have that come into the world. And on that note, as I said, we're just getting all of the ducks in a row to launch the training, and it's currently being finalized, but please do bookmark these links and keep an eye out for our official launch in the next couple months. The link here, as Felix had highlighted earlier, is egale.ca/QMH, and it'll also be all over our socials once it's ready to launch. And it'll also be on the French landing page, which is hyperlinked here as well. So that brings me to the end of the formal webinar, and I will open it up for Q&A, but thank you so much for your attention, and I'll pass it off to Erin.
Amazing. Thank you both. I know as an Egale employee, there's always so much going on that I rarely have a moment to be able to figure out what our research team is up to. So I was very glad to be able to attend and learn some more here. And I've placed the English link in the chat. I will put the French one as well. I just have to grab it just so folks have access there. Let's see. I also want to just share this comment that was put in the chat by Felix. Shout out to Krista and Egale's learning team for their wonderful work on the training modules. I love our training modules as well. Someone asked, could those of us who joined the webinar today be sent a notice when the training goes live? Is that something that we're doing? Do we know?
I believe that should be, oh, sorry, go ahead.
Kim. Go ahead.
I believe that should be doable.
Okay.
If we have folks' email addresses and they're all right with us sending that.
Yeah, I definitely can help with that as well. Thank you for asking. We will make a note to do that. Let's see. So we have a question here that says, do you think this training is directed at providers who aren't already doing this work, or for providers that are already doing this to some degree?
Did you want me to answer that, Felix, or do you want
to? You can complete my answer, and I'm gonna respond to everybody. Why
Sure.
not? I think that the inclusion 101, well, the first module, which is based off of the inclusion 101, is kind of the basics of what it means to be affirming for 2SLGBTQI people, and then the rest of it with, we can never know too many things about intersectionality or minority stress or these kinds of things. So my first response would be that it's appropriate for everybody. If you want to complete, Kim.
Yeah, exactly. So echoing Felix said, say that it is directed toward everyone. Of the two, the Inclusion 101 trainings are more directed to folks who really lack familiarity with things like, the core terms and concepts and that sort of thing. And then this training is digging a little bit deeper, but as noted, the first module does provide a higher level overview of a lot of the content that was covered in those 101 trainings. So it would certainly be viable for anybody to take the training. And as Felix said, a big part of cultural humility and cultural responsiveness is having this approach to lifelong learning and to revisiting things and to, just kind of being open to learning things that you think you already know, right? So long-winded response to say, yes, I think it would be open to everyone.
Awesome. I also want to highlight that Brittany is being wonderful in the chat, has shared that there's also a link for folks to subscribe to Egale's newsletter to get updates on things like this as well. So that is available there. We have another question. Someone has asked if either of you have any recommendations on publications where they could read more about the training or lack thereof that providers spoke about.
So if you, shameless plug, if you read our research report that's on egale.ca/QMH, you could scroll down to our reference list where we cite others' work that's quite recent in the last few years on things like training gaps and knowledge gaps. So in the section where we talk about service providers' experiences and challenges, that section, wherever we cite folks, that would be maybe a place to start. And there's also going to be an academic article coming out specifically on service provider challenges, which it includes a lot more citation and resources as well. And that will be posted on the landing page once it's ready for the world to see as well.
Amazing. Okay, I'm going to read out this question. Was there any feedback by 2S LGBTQ+ providers that having other peers in the space to connect with helped their burnout isolation learning, aka peer support? Or was that just a double-edged sword, being like, this is a peer and not someone who would be able to give me care, even though they are the most qualified? That's a great question.
Felix, I'll just respond quickly and then I'll pass the baton to you if that's okay.
Yeah.
That is a really good question, and I can just respond based on my own interactions with the research participants and with the data. So in a couple of our focus groups that came up actually, and folks talked about this largely in terms of the former. So they actually found it helpful to connect with other people that were going through really similar things that they were, especially since the last 3.5, 4 years have been so isolating, that being in, even though it was a virtual room, it was done over Zoom, but having that opportunity to not only share their own experiences, but see how closely it overlapped with their peers was actually something that gave them some kind of comfort, albeit, there are these broader issues of realizing the limitations, especially like I noted earlier in rural and remote communities where there's like 1 degree of separation between folks, and it's difficult to access care as a service provider if you are the only one or one of 2 people providing it, right? So, but I did find just in those interactions with service providers who participated in the qualitative component of the research that they did find it quite healing to be in these conversations and hear what other service providers across the country that may be working in a very different provincial context, in a very different sector even, a counselor versus a social worker working in a school versus, a private practice, that they're experiencing these really similar things. Felix, do you want to add to that at all?
I can't think of anything to add. Thank you for your very thorough answer.
Yes, it's always interesting to see the community building that can also come out of these projects when we're learning from folks, how much they also end up learning from each other.
Yes, exactly.
All right. Someone here asked, because the healthcare system across Canada is provincial, how do you standardize your metrics for queer health across Canada?
So the goal of the research that we had was mainly about documenting the experiences, right? So, and across Canada. So I'm not that like where you live is not important. It is absolutely important, but we were mostly interested in at least for the survey. So I took responsibility for most of the analysis for the quantitative part. And the provincial context did not take a major place in the way that we analyze the data, although it is always possible to go back and see if there are differences. But for the time being, we were really interested in the kind of national, global experiences of folks. One thing that seems to be a constant thing is that mental health care is difficult to access, and those who provide the services are very busy, if not tired or burned out, right? And this regardless of the province. I can't remember a survey responded saying, oh, everything's going well in the mental health care system in my province. So in terms of metrics and measuring the experiences, we had the set of questions that we talked about a bit earlier, and then we kind of tried to extract the trends from all of that. If I remember well, Kim, we did have a fairly good representation of folks from across Canada, so from all the provinces in our survey sample, and the experiences were fairly similar overall.
Amazing. We have another question here. As mentioned, mental health care providers typically take on the responsibility for making low-cost care accessible. I'm wondering how this research is being used to lobby, fundraise, etc., to help make affordable care accessible while providers still get paid.
That's a great.
We hope that the training, for example, will be one of the means that is being used to raise awareness around these issues. We need to talk about it as much as possible. Thank you, everybody, for being here today and for listening to us and for raising your own awareness of these potential issues. A big part of the project, and Kim, you can probably talk about this a little bit more, but all the knowledge mobilization efforts. So really taking the results, the research results, and throwing those out there to make sure that as many people hear about those as possible.
Yeah, exactly. So just building on that, knowledge mobilization is happening online. It's happening with us presenting a public webinar like this, and as well as going to speak to different audiences. So, typically at a conference, you'd be speaking to academics, but we're making sure to speak to other audiences like leaders of national and provincial mental health associations and organizations who have already expressed interest in this training, speaking to public health folks who and policymakers who have different social positioning vis-a-vis changing the structure, right? And so really making concerted efforts to ensure that our knowledge mobilization is focused on a variety of audiences beyond kind of the usual suspects of fellow nonprofits or academics. We're really making efforts to broaden that scope so that we can accomplish our goal of achieving broader, more structural change. Because as you noted, this is not something, the onus should not be on the individual to make their care more accessible. It needs to be a structural approach, a systemic approach to that issue. So just building up on what Felix said, our knowledge mobilization strategies are really keeping that in mind.
Awesome. I want to thank you both for taking the time today to share this research with us. Not just because I am super curious about it and enjoyed learning about it, but for doing that work of knowledge mobilization and getting as much info out there as possible. It has been a real treat today. And we have a few more minutes, so if we do have any more questions come in, please send them our way. I was wondering if there is an email that folks can reach out to if they have more questions. I'm not sure if that is already on the QMH page. Yes, I see it actually. There at the bottom here, it says, for further questions on this project, please email research@egale.ca. And Felix posted it right there in the chat. So
with the typo at first.
So if this was a lot of information and your question hasn't formed for you yet, that is the place where you can reach out to us as well, and we encourage you to do so. I'll also add, I don't know how much either of you can see the chat, but you have gotten many, many thank yous and a lot of people very excited about this content.
I'm just scrolling through now.
Yeah.
I see Carmina is here. Hi, Carmina.
Yeah, now's the part where you shout out everyone you recognize from the audience. Awesome. Okay, it looks like that will be the end of our questions for today. So we're getting some highs now. That's funny. So thank you everyone for attending. We look forward to sharing more things like this with you in the future. And we hope you have a great end of your day.
Thanks, everyone.
Thank you. Thanks everybody for coming.
Thanks, Erin, for facilitating.
Yeah, thanks, Erin.